FootSecure and Stride 8 proudly presents this citation for delivering the FootStride Oration to Dr. Kalkunte R, Director, Jain Institute of Vascular Sciences, Bangalore. Dr. Kalkunte R was born on 13 December 1948 in Mysore, Karnataka. He completed his MBBS from Bangalore Medical College in 1972. He then moved on to the United States, where he pursued postgraduate surgical training at the State University of New York. Between 1976 and 1982, he served as a clinical instructor and the chief resident in general and vascular surgery. From 1982 to 1992, he practiced.
You can stop the audio.
As a consultant to 1992, he practiced as a consultant general and vascular surgeon in Fort Myers, Florida. In 1983, he returned to India and joined the Malya and Manipal hospitals, Bangalore, as a consultant vascular surgeon. Even in the absence of formal vascular training programs at that time, he introduced vascular procedures and mentored surgical registrars, laying the groundwork for what would soon become a national movement in the vascular care education. In 1999, he became the director and senior consultant vascular surgeon at Jain Institute of Vascular Sciences, JIVAS. From March 2002, he also served as the director of Vascular Fellowship Program. Under his guidance, in 2003, JIVAS launched the 18-month fellowship in vascular and endovascular surgery. Dr. Suresh also authored the official syllabus and curriculum for the DNB program in vascular surgery, which has since been adopted nationally. In clinical innovation, Dr. Suresh performs the Bangalore's first carotid endarterectomy in 1993. In 1998, led one of the first EVAR procedures by Indian team. In 1997, he founded the Bangalore Vascular Club, which later evolved to the VASCAR Society, the Karnataka's official vascular platform. In 2001, Dr. Suresh became a founder and life member of the Diabetic Foot Society of India. He served as a treasurer from 2001 to 2005 and later as a vice president in 2014. His contributions to the diabetic foot field are both deep and wide. He was co-author of the National Guidelines of the Diabetic Foot published in 2006 and in 2017. He contributed to the Handbook of Diabetic Foot Disorders published by DFSI. He has been instrumental in advancing diabetic limb salvage protocols, combining revascularization, wound care and team-based management. Through the Atreya Vascular Foundation, he created financial pathways to treat underserved diabetic foot patients, supporting over 800 arterial procedures, including limb salvage surgeries at little or no cost. His work made limb preservation accessible to the poorest patients, particularly in the rural Karnataka. In 2007, he initiated a mobile foot and vascular screening unit, which over 15 years has screened over 2.5 million individuals, with particular emphasis on diabetic foot risk assessment, including vascular evaluation and educational in rural and peri-urban communities. The mobile unit still runs 18 village visits per month. He has trained over 200 diabetic foot care workers, including nurses and paramedical personnel in foot screening, ulcer care and basic offloading. Even today, at 75, Dr. Suresh continues full-time at JIVAS, focusing on teaching, research, mentorship, outpatient care and institutional leadership, having handed over the operative responsibilities to the new generation of surgeons. On this 25th day of May 2024, we at Podocon recognize and celebrate the monumental contributions of Dr. K.R. Suresh to the science, service and soul of diabetic foot care in India. We honor a surgeon who has not only saved limbs but shaped lives, institutions, guidelines and futures. May the Almighty bless him with continued strength, fulfillment and peace.
Thank you, sir. Can we have Dr. Suresh on the dais, please? He's one of the most grounded doctors that I have seen in my short life so far. And no chair. That was the first condition that he put us, that you're not going to call me on dais, put me on chair and make a guinea pig out of me. But then, sir, we have to do something which we as juniors will have to say thank you in a small way. Can I request Dr. Sanjay Vaidya to honor Dr. Suresh? Sir, can we have Can we have it there, sir? Over to you, sir.
Wow, that was a very generous introduction. Thank you all. Thank you for being here. And I want to talk about a little bit about vascular surgery. That's my field. And I want to give it's not a clinical presentation. This is not going to be about teaching how to diagnose. I say how we have changed, how we have moved forward in the vascular surgery itself over the years. Now, vascular surgery involves mostly the lower limb. So we do carotids, we do aneurysms, etc., but I'm not going to concentrate on those things. It's going to be purely in the lower limb. So, I'll try to make it move. Okay. So what I'm going to do is, I'm going to see how we have shifted, paradigm shift in our treatment of vascular diseases. Okay. Now, what's a dysvascular diabetic foot? See, and we, as a vascular surgeon, 80% of patients are diabetics. They like it on. They come with a wound, multibacterial wound, as we discussed about. So, what is a dysvascular diabetic foot? Any diabetic foot which has a PAD, non-palpable pulses with the ABA of less than 0.9, it is dysvascular diabetic foot. Doesn't mean to say you have to operate on them, but you have to be doubly careful about what to do with them. What is the paradigm shift we are talking about? You know, we are known as vascular surgeons, which means we cut and sew. That's changed. So the paradigm shift came about 2 decades back almost, when we started doing endovascular procedures, which is minimally angioplasty, balloon plasty, and others. We learned from our cardiac surgeons who have become kind of a nomads because everything is taken over by cardiologists. This is the only holistic field today, vascular surgery, which combines everything. Especially in Bangalore, which has 43 vascular surgeons, endovascular 90% done by vascular surgeons. Very little by interventional radiologists and less so by cardiologists. And we are doubly equipped to do that. We are the only one who can do operate, to do endovascular, do contact, medical science, etc. So I'm glad to see Dr. Nambiar's field said vascular surgery somewhere there. Hopefully that'll be reality in future. So when we change our course to being surgeons to a true specialist, what do we need to do? This, I think, applies to a lot of specialists, like you're talking about how we have to rethink tools, especially go to research and other things. We have to rethink. We have to rethink the strategies of patient care. We can't just go and operate on them. So since you have this modality which is combined and multiple, hybridized, we need to rethink how we go and do that. Then how to retool. We are not used to just knives and scissors and cuts anymore. We will learn about other tools like wires, and etc., etc. I'll come to that in a minute. And obviously, we need to upscale our things. We are operating before, and we are not used to endovascular like radiologists and cardiologists were, but we rapidly learned how to do these procedures in a very rapid way. We had multiple, in Delhi, we had animal lab, etc., etc. I conducted about 12 programs to turn the vascular surgeons into endovascular surgeons. My first attendance was 1988 in Santa Monica, where there was a program about endovascular surgery for vascular surgeons. At that time, I said, this is the future. We have to combine it. Not at the expense of surgery, in addition to surgery in combination, to complement the surgery. So then, we also have to rebuild. Rebuild means we need to have quite a cath lab, we need to have a C-arm, which we didn't have before, and we need to change the concept of what we do in the operating room. It's called hybrid operating rooms. Now, just a little obedience to our precursors, you know, or the innovators and so on and so forth. Anybody should know this Alexis Carrel name. He's a Nobel laureate in 1905 who did the first vein bypass in a dog, reverse vein bypass. He won a Nobel Prize, not for vascular surgery, but for kidney transplant. He did the first kidney transplant in dogs. He won a Nobel Prize. And the thing is, he also wrote a book called Man the Unknown, which won a Booker Prize. And then the incomparable William Halsted. Any surgeon will know his name. Surgeon said the biggest problem for a surgeon is bleeding. And his seminal statement that the surgeon's skills are measured by how he handles the blood vessels. That is really the baseline for a vascular surgery. Then Michael DeBacchi, I don't know if any doctor would know his name at all, magnificent innovator. He converted, his wife sewed the first graft for aortic aneurysm at home. Dr. Nambiar, can you believe that? At home with the silk, and he did the first aneurysm with that. Okay, then innovator, he did the first carotid endarterectomy for prevention of stroke. And then came Thomas Fogarty. Everybody knows, surgeons know Fogarty catheter, which removes the clots. And before, it was an arduous procedure to open the blood and take the clots out. Fogarty was a technician. He was not even a doctor at that time, about 60 years back. He invented this Fogarty catheter, which still stands, holds good today. That's innovation. Simplistic, but incredible innovation. The biggest innovation that's come to the world is a safety pin. It holds off today also. And then 20 years later, first coronary stent was implanted in France. But before that, Charles Daughter, in incredible ingenuity, he was a radiologist, opened up a occluded femoral artery with the bougies, with the Hagar dilators. He trusted into them and opened them. That started the endovascular intervention. Then came Julio Palmas, who made the first stent, and Palmas stents are still available. And then Juan Carlos Parodi. Aneurysm was always a surgeon's domain. He made an endovascular domain. Parodi was a vascular surgeon from Buenos Aires, Argentina. I know him quite well. He did the first endovascular repair. This changed the whole shift. The paradigm shift happened because everybody thought it's foolish to do an aneurysm in endovascular, minimally invasive. We do it now in 45 minutes. Patients are home in 2 days, as opposed to 1 week in ICU, etc., etc. And this is Roy Greenberg. He died when he was 45. You know why he died in 45? He was an incredible innovator in endovascular surgery. He's a surgeon, Cleveland Clinic. He died of mesothelioma because he didn't protect himself from radiation with the turning around. So he died when he was 44. And the amount of research he has done in the new kind of technologies, how to construct a guide wire, from that onwards, how to implement that is incredible. The innovators. My seminal moment with this gentleman, whom you've seen before. This is Robert Rutherford. He wrote the first textbook of vascular surgery. I had the opportunity to share with them in Bangkok session, and it was really thrilling, and I was really scared. And then this was his first book. You just notice that it's vascular surgery by Robert Rutherford. But look at it now. Look at the title. That's paradigm shift. Vascular surgery and endovascular therapy. Now, vascular surgery has become magnificently high in endovascular. We have beaten radiologists and cardiologists flat out in doing this. Now, this from the DNB curriculum, which I wrote. I was a one-man commission for that. You know, I'm going to consider only a lower extremity because this vascular diabetic foot. You look at this. Everything has, if you look at this, everywhere there's vascular surgery, endovascular, vascular surgery, endovascular procedure. No other curriculum has combination of vascular and endovascular procedures. Okay. Then you look at this pretty anemic cardiothoracic vascular surgery. In India, CTVs doesn't exist because cardiac surgeons have no idea about vascular surgery. I'm unabashed in saying that they really don't even know the blood vessels of what they're doing. This is their curriculum. 15 venous and 15 arterial surgeries. That's whole curriculum of vascular surgery. The curriculum I wrote has 300 minimum procedures done by vascular surgeon to be competent, especially for the lower limb. Okay, enough of that gloating about vascular surgery. Then what the vascular surgeon needs to, what's the armory of vascular surgery? We look retool. Then we need to do something else. We need to hybridize. We need to transform ourselves from scalp-wielding surgeons to an endovascular procedure where we can do all kinds of things. So what we become is essentially a vascular specialist. I really hate to be called as a vascular surgeon anymore, but the term is stuck. We are incredible vascular specialists. So we need a lot of tools. What do we need? We always had knife with our hands, no question, the grafts and so forth, which is used, endografts. Now, we need to really learn about guide wires and etc. we should do now. More than that, we need to know how to stents, and then how the innovation about the triggering system which deploys the stents. But the bottom line, never forget, only 20% of vascular diseases require intervention. Other 80% do not require intervention. They're good medical care. Unfortunately, too many bypasses, angioplasties are done because there's a disease present. That's not true anymore. Whether cardiac or peripheral block does not invite intervention. Symptoms invite intervention. So never forget it. Never forget foot care. In India, our 60% work is in foot. If you don't provide a foot care, it doesn't matter what a beautiful surgery you have done, they will come back with the infection. And it's been well discussed this morning. There's no way you can do without foot care. If you look at this, is very telling thing. If you look at it, how do you determine the patient requires intervention? Do you see any X-ray, any radiology, any CT scan, MR? No. It's purely clinical decision. Patient has progressive symptoms. Firstly, they don't require procedure. It doesn't matter what block they have. The last two require intervention because limb-threatening ischemia. They lose the limb. Amputation not an answer. I'll show you why amputation. They are horrible procedures that can be done. Now, very important vascular surgery. Diabetic or non-diabetic. No symptoms, no intervention. Absolutely true. It doesn't matter what block they have. Claudication is a very, very stable disease. Only 3% of claudication. Claudication means people who may not know it, pain on walking, they have to stop their work again. Only 3% go to limb loss over 3 years. That means you have to do 97 unnecessary procedures to save 3 patients. So you don't do that anymore. But the caveat is, in India, is from external wound. So what do? You prevent a wound, you prevent an amputation. We know that 80% amputations are preceded by a wound in the foot. How do you prevent? It's a simple footwear. At home, especially in the temples, notorious temples. I mean, all the diabetologists, everybody know, they walk in the temple in the hot stone, they get a blister, and bingo, before they know, patients don't have sensation. They don't come to you for about a week, 2 weeks, and by the time infection. So what do you need is footwear. Now, he's one of our rural patients. We taught him that he should wear a footwear. He's wearing a footwear. Would you call this a success or a failure? I don't know. You decide. He's wearing a footwear. He wears something. Not appropriate footwear, but wearing something. So we have called HJ. We see about 40, 50 wounds per day. And then we have a huge rural program. Now, there's a global burden of CLTI is a new term. CLA was an old term. I'll tell you why. Chronic limb-threatening ischemia. You won't be able to read this slide. This came from folks and all. I was a co-author of this for about 15 years back. The problem in India is a significantly increasing. More worrisome is young women with PAD. If you look at endovascular, the increasing in PAD in women, they're non-smokers, most of them, even though they use smoking. PAD is increasing. And unabated smoking, we know the diabetic capital. We have crossed over 100 million, 70 million diabetics. Even if you take us 10% vascular disease, that's a huge number by itself. So CLTI is a new term. You all know CLI means critical limb ischemia. When you have a wound, you don't do something, you lose the leg. The caveat for that was you need ankle brachial index, the blood pressure difference between the arm and the leg. That should be less than 0.5. That caveat is gone because you see a lot of diabetics which have prominence. Now, any wound in diabetic with the ankle brachial index of less than 0.8 is limb threatening. It's been well studied, well conducted research, and well written. I'll show you in a minute. And then, so immunology is chronic limb threatening ischemia, critical limb ischemia is gone. So if you look at how the effects are affected, majority effect is not in the heart. If you look at it, about 50-70% are in the leg. So leg is the mirror of the body. If you have it in the leg, it shows the highest atherosclerotic burden of the whole body. If you have a heart attack, like 30% have disease elsewhere. If you have a leg attack, if you call it, the ischemia, 70% have somewhere else. They already have in coronary arteries. So this is the distribution from a Dutch epidemiological study, which showed the distribution in lower limbs extraordinarily heavy. Now, if you look at the fatal patient, they are never one level. Unless coronaries and others, the carotid is one level disease. There are multiple levels. The aorta, lower limb, starts the renal artery. That's where the lower limb blood vessels start. They're all over there, multiple diseases everywhere. So none of them you can do with a single procedure. One bypass, one angioplasty, no, you require multiple procedures. Especially in India where they come with a bad wound. Now, one more thing, very important, all patients with PAD require medical treatment. Why? If you have a heart attack, you have a 30% chance of getting a heart attack in the future. If you have a PAD without symptoms, you still have a 30% chance of getting a heart attack in future or a stroke. So it shows the systemic atherosclerotic burden, and they should be treated aggressively medically. Not to correct the leg. No, you have no business correcting a blockage on a guy who is walking 1 mile or 1 foot. So it's a leading indicator for whole atherosclerotic burden. So they need a good medical care with aspirin, statins, etc., etc. So if you look at it, what happens to patients here? Now, this is our own data. 70% now is endovascular. So right or wrong, I'm not sure. I'll go through that. And about 20% open surgery, which is a total reverse paradigm shift from what it did 15 years back. 15 years back, 80% open surgery. Now, and then there's hybrid glam. Now, we don't want somebody doing angioplasty one day, next day, and go to bypass. That's not good for the patient. We do them together. We do a lot of hybrid. We have cath lab of our own. We have 2 cath labs, vascular. Cardiology has only 1 cath lab. We have 2 cath labs. We do angioplasty, like iliac angioplasty, FEMPOP bypass, 1 shot. Or FEMPOP bypass and distal angioplasty below the knee at 1 shot. There's no reason to do them separately. That's what we used to before. We said to radiology, they would do angioplasty, then come back and do a FEMPOP. I think those days are gone. That's the paradigm shift. Very important slide. There's concept that why do all this vascular surgery when you can amputate? Just look at this. This is not my data. This is world data. Real world data come multiple. Pancreatic cancer, lung cancer have shifted number 1, 2 positions, a very poor 5-year survival rate. That not changed with billions of dollars and 50 years of research. Unfortunately, it remains. With the third highest is amputation. Not many people know that. Why is that amputation third highest killer? Because this comes from West, where they have an amputation and a fantastic prosthesis, they can run with that. Every time with a good prosthesis, you walk, below knee amputation, you walk, you increase your heart rate by 40%. Above knee, you increase by 60%. You're doing extra cardiac work. So these people cannot tolerate, they already have cardiac disease. So amputation is not an answer. And amputation is cheaper? No. In our own experience, we know the first week expense of bypass or angioplasty is high. Look at 3 to 6 months, it's enormously high. It's double because multiple admissions, infections, amputation does not do well. Plus, 20% get other foot into trouble because of the weight bearing. Now, let me just show you. This is the latest that came. This is now the Bible for vascular surgery. This is the Global Vascular Guidelines, and this is my time to brag about myself. I was the only one from Asia in this 9-member group, so we had a lot of work on it. And we got data from all over the world. And I'm glad to put Bangalore and Jain Institute of Vascular Sciences in the globe here. Now, I also wrote the editorial. Now, let me show you just one patient stratification. This could be daunting for non-vascular surgeons, but it's pretty simple for us. Let's do this 80-year-old gentleman, typical diabetic, smoker, etc., the right to gangrene. ABA is 0.69, is above the CLA level. Now, this patient will be dubbed as high risk. Now, when we do this system, we have to identify the patient, go through the steps of what he requires. This patient requires intervention because already got a gangrene. So how do you do that? There's a plan system which comes through the GVG guidelines. This is not, it's a mnemonic. Please never forget the patient factors, the biggest determinant. One big determinant, patient factors, diabetes, renal failure, etc. Then you should have limb factors. The biggest worry of limb factor, the determinant or a negative determinant of an outcome of a vascular reconstruction is limb factor, infection. I'm surprised that nobody mentioned Wi-Fi classification. That's what is used for infection today. Other factors are gone. We got to use Wi-Fi classification. Wound, ischemia, foot infection classification for that. Then comes the anatomic factors, where the block is, how long the block is, etc., etc. That's all built into this plan system. You put all this into a bowl and then come out with a decision as to what to do with the patient, not by isolation of these things. Let's look at this patient. If you look at the leg up here, this is long segment femoral block. That we can do an angioplasty, but it won't sustain. Femoral artery is the toughest artery to keep open in the body. It's got a stupid femoral artery because it somehow occludes, tries to beat you every time. This is a long block. This needs a bypass. Now, if you look here below, there are a lot of blocks here. So your purpose is to get the blood going into this. So this patient has 2 blocks. So how do you stratify this patient? First thing to stratify is risk factor. How do you risk factor? Now, in vascular surgery, there's only average risk and high risk. There's nothing like low risk, unfortunately. They're inherently unstable patients once you get critical limb ischemia. It's like I'm an unstable angina. Something's going to go wrong. So how do you do that? This patient will be dubbed as high risk because 80-year-old and had a heart failure, diabetes and all. He's not. So there are calculators available. We use what's called VQI calculator. If you look at it, his operative mortality is only 0.2%. It's extremely low. Just because 80 doesn't make him high risk. And then what's the 2-year life expectancy? That's important. So you don't want to do a major procedure for somebody who's going to have a pancreatic cancer, not going to survive for 6 months. His life expectancy is 4 years. So where do they belong to? These are daunting, but we don't calculate this. Everything is an app at your fingertip. One click of a button and you get the result of these things. You don't have to sit on the calculator. So he is average patient. So what do you do with this patient now? Now, next is the most important. This is what defeats a surgeon, the limb factor. So he's got a toe amputation. We all know diabetic. Now, this is the so-called Wi-Fi. Daunting, 64 squares. Even the authors, Joe Mills, the author, even he can't remember what he's doing. So we have a calculator again. So where does this belong to? If you look at him pre-debridement, is stage 2. It's a progressively increasing stage 1 to 4, which takes into ischemia, the wound infection, etc., etc. Now, if you debride him in India, you know that you come to toe gangrene and you debride, you change the whole complexity of the patient. So after you debride him, he goes to advanced stage. Stage 4 is the highest risk for the limb loss. So we have to calculate this patient, the patient's algorithm before you decide what you're going to do with the patient. Again, calculator, tip your fingers. Now, this patient, let's see, then we come to vascular. How do you calculate vascular? This is, a lot of you may not be aware of it, but some might be erudite with this. Now, we look at the femoral lesion. His femoral lesion is long, as I told you, up here. So where does it belong to? It belongs to class 3. So that's a long lesion. Then, if you go to lesion in the infragenicular segment below the knee, so this is not too bad. So this belongs to class 1, so stenosis. So you have 2 classes in this patient. So what do you do with this patient? Now you plot those 2. 3 and this 1. It's pretty easy. He comes to stage 2, which means he's a dealer's choice. You want to operate? Go and do an open operation. You want to angioplasty? Do an angioplasty. So it can belong to both. So if you plot them, he's a moderate risk patient. We plot Wi-Fi, the glass stage, everything, and he belongs to the gray area where it can do both. If you look at only this disease here, that should have bypass done. This not now with endovascular surgery. Unfortunately, it's being done. People who cannot operate end up doing a angioplasty and does. That's not acceptable. Then the one below, you can do an angioplasty. But he has both. So what do? We hybridize. We do FEMPOP bypass, and during that time, put a wire down the leg and do an angioplasty, which very commonly we do it. We do about 5 arterial procedures a day. Now, our own data to share something. We have done about the time period about 6,000 lower limb revascularizations. We were able to calculate about 3,000 of them been analyzed performed by 4 surgeons in our department along with the postgraduate students which we have. It's a retrospective analysis, prospective corrected data. So this what comes as total number of surgeries 704, 3,000 endovascular hybrid 127. So endovascular dominates because the recent Now, if you look at it, I'll skip this. Age is same, and female are getting more endovascular because the more disease rate. Then most of them are smokers. But this is an interesting slide. If you look at the coronary artery disease, we assume they have a coronary artery disease. We do not repair coronary artery disease. We do not work up the coronary arteries. It's not required. They will have disease. It's a misnomer to say they all should have coronary evaluation. No, that's actually a negative factor if you do that. So this is 31% had coronary artery disease before 2012, because cardiology insisted they do coronary angiogram, so most of them had disease, so we ended up not doing them, just doing an amputation. What happened in 2012? We stopped doing coronary angiogram. We stopped doing coronary workup. Stopped doing chest tests, because that doesn't change what you're going to do. The outcome is no different. I mean, if you correct the coronary artery, you're not going to get a better result. If it's symptomatic for coronary artery disease, then you correct that. Asymptomatic, we don't even look at it anymore. Not required. That's well borne out by all our studies. So after that, 73% endovascular had coronary, 70% endovascular, because we included a lot of patients who would have been refused because the echo showed a 33% ejection fraction, and did a coronary angiogram, triple the disease. We don't do that. Because you come with ischemia, you don't have time. You have to do them within a week. And the cardiologist put a stent, regular stent, you cannot operate for 6 months minimum. So you can't wait for that. So that change, that's a paradigm shift, that we don't really work up coronary and just do them. Now, if you look at, this is just showing that the wounds, the diabetologists understand the categories 4, 5, 6, massive number of wounds in this patient. So we do not operate for claudicators at all. We don't. They do well on medical treatment. This is only in limb ischemia. There's something interesting here. I know this could also be a confusing slide. If you look at our death, it is 9% 5% of cardiac death. It's pretty high, and 16% underwent amputation. These are the 6 months. That looks like high. But of 2012, it came down. Even though we were treating more and more of a heart patients, it came down because it improves the technique, improves our anesthesiology, we do it more local, and good post-op care, good wound care. Most of them died because of the wound became septic. And our amputation rate came down too, considering we are doing more risky patients. Now, is there a evidence to show the paradigm shift? We had gone for surgery into endovascular procedure. Actually, if you look at open surgery, it's a very, very strong evidence, very robust, built over the last 50 years. Hard to beat that. But if you look at endovascular, it's not so strong. It's very weak witness to endovascular procedures and minimally procedures. So, should endovascular be offered to patients? If the data doesn't suggest, why are we doing endovascular procedures on this patient? Yes, for multiple reasons. Where we are doing a first-layer approach. But remember, best medical, this is something out of the context. Best medical care is not what the evidence-based medicine says. Best medical care, this Archie Cochran, who did Cochrane reviews, said, best medical care using best available evidence, acclimate us to your patients and surroundings. We can't do what the Western do. Clinical researchers go through a very clinical aseptic conditions. Our patients are real-time patients we have to adopt and change. If you look at this data, just to put it in, limb salvage, this open surgery is very high. And patency is very high, 90%. There's no way you're going to get that with endovascular. But if you look at this, again, same thing shows that patency of endovascular is very poor. 1 year, 2 years, 3 years. Why are we doing it? Even if you look at it again, 3-year patency bypass is 70%, 3-year patency of endovascular is 50%. Are you justified in doing it? Now, why are we doing it? But one thing is, now we've changed our concept that when you post revascularization, our aim is not to see how long it stays open. Our aim is to see, can you heal the wound? And can you keep it healed? AFS, amputation-free survival. That is the goal. If you look at that, endovascular and open surgery go hand in hand. They're pretty much equal. So there's a definite evidence to say endovascular is acceptable. So that's why I said, even though it's inferior, there's nothing is going to beat a bypass. It's not even come close. Maybe in future it does, but it will not beat a bypass. So, but limb salvage and amputation-free survival is very high. But other thing that happened, previously so-called patients we couldn't do bypass. Now we are amenable to endovascular procedures. High-risk patients are amenable to endovascular procedures. So we can salvage their limb because we don't want an amputation, which is a very morbid condition, not socially, but even medically. Now, this is a foot clinic. I'm going to end with pride and joy, the foot clinic. We were the first ones to start a foot clinic. And she headed up a Vinia who was sitting right there. And then, this is a pride. This is a new foot clinic we have now. And bigger than that is what we achieved in this. This is a rural clinic we have been doing for now almost 22 years. We go to villages 18, 20 days a month within 100, 120 kilometers, Bangalore. And this is mostly screening, counseling, and see how we can treat it in primary health centers. Now, if you look at that, this is a stunning number for me. It's increased it for 1.2 crores without any cost to the patients. All funded by our goodwill, good wishes, and good Samaritans. And perhaps this takes the cake. It's nice to do endovascular, make more money, and put a stent. But this is what we are very proud of. Now, if we can continue this, combined with other people, we can really save the limb and go on ahead. I think I'll end with this. Thank you very much.